I'm Allison Kurian from Stanford University, and I will be speaking today on an update to the breast cancer genetic testing guidelines. The new testing guidelines of the American Society for Clinical Oncology and Society for Surgical Oncology are shown here on the screen, and they are relatively brief. The important things here are recommendation 1.1, which is that all patients newly diagnosed with breast cancer with stage 1 to 3 or de novo stage 4 metastatic disease who are 65 years or younger at diagnosis should be offered BRCA1 and 2 testing. The other key new recommendation is that patients undergoing BRCA1 and 2 testing should also be offered testing for other cancer predisposition genes as suggested by their personal or family history, and they remind us that consultation with an experienced provider is wise. As we look at recommendation 1.2 and 2.1, these cover other reasons for testing. And a key one here for us to remember is targeted therapy with the poly-ADP ribose polymerase or PARP inhibitors, which I'll discuss further. So where did 65 and under come from? There are a few papers that really serve as the basis for this recommendation. And one of the important ones was by Yadav et al., published in the Journal of Clinical Oncology in 2020. And so what they did here in a clinic-based sample of 3,907 breast cancer patients was to look at sensitivity of various testing criteria for 9 important breast cancer-related genes. When we look here, we see different criteria, including the ASBRS criteria, which is basically to test everybody with breast cancer, the NCCN criteria, which were more limited at the time than they are now, and then a combination of the NCCN criteria or age at diagnosis in years, whichever came first. And so what we find here is that when they picked the threshold of age 65 or younger, they got to a very good sensitivity of 92% for this combined metric of NCCN criteria or age at diagnosis, whichever came first. And they don't show it here, but they also had 98% sensitivity for detecting BRCA1 or BRCA2. And so that has been rationale for why we might think about 65 and under as a cutoff. And another key line of evidence came from some work that I present here. We did this study in the Women's Health Initiative dataset. And in this case, we randomly selected 2,195 breast cancer cases that occurred after menopause and 2,300 controls. And our question was, what was the contribution of inherited genetic mutations to postmenopausal breast cancer? We know and have known for a long time that early onset breast cancer has been strongly associated with genetic mutations, but what about after menopause? And so here, what we saw looking by age at breast cancer cases was for BRCA1 and 2 here in blue, a prevalence of about 2.2, 2.3% for women aged 64 and younger at breast cancer diagnosis. When we looked across other breast cancer genes here in red, we see slightly lower prevalence, but it's quite consistent and really doesn't fall with age. And so we see this persistence of other breast cancer genes. And so the key points here were that the BRCA1 and 2 pathogenic variants were found in 2.2% of patients who were diagnosed at age 65 or younger. And that is similar to the prevalence of BRCA1 and BRCA2 mutations in people of Ashkenazi Jewish ancestry. And that has been a criterion for testing for a long time. So I think this provided additional information to support 65 and under. And I would just note that other breast cancer genes were present in 2.4% in all ages studied in this postmenopausal group, again, making the case for considering testing them when we are testing BRCA1 and 2. Then there's the issue of PARP inhibitor eligibility, and this is from the Olympia trial. The Olympia trial looked at an adjuvant PARP inhibitor, poly-ADP ribose polymerase inhibitor, olaparib, in curable stage 1 to 3 breast cancer that was ER positive, HER2 negative, or triple negative. And this was after sometimes neoadjuvant chemotherapy, sometimes just surgery and radiation, but giving a year of olaparib after that versus placebo. And what we saw here in this trial by Tut et al. In 2021 was really a striking difference in disease-free survival of 8.8 percentage points, which is bigger than we see for many approved drugs in early breast cancer, and very promptly translated into an overall survival benefit in a paper a year later. So this was a very positive and exciting trial. To my knowledge, it is the first example of approval for a germline target, namely BRCA1 and BRCA2 here, and it makes it imperative that we don't miss patients who could stand to benefit. So which other genes should we test and why? Here I'll provide a few lines of evidence from two key studies, one of them being the Breast Cancer Association Consortium's BRIDGES study in the New England Journal of Medicine in 2021. This was a very large case and control study of several thousand cases, women with breast cancer, and several thousand controls, and really gave us some of the best data that we'll ever have. And what we can see here is overrepresentation in light blue of several well-known genes in cases versus controls. So BRCA1 and BRCA2, but also PALB2, TP53, CHEK2, PTEN, ATM, and others. And we see here the associated lifetime absolute risk of breast cancer for BRCA1, upwards of 50%, BRCA2, between 40 and 50%, PALB2 close to BRCA1 and 2. Then we see the more moderate penetrance genes, CHEK2 in orange, ATM in yellow. And then three interesting genes, BARD1, RAD51C, and RAD51D with dashed lines. And these are the ones that are moderate penetrance ER-negative breast cancer genes compared to population-based risk. The other very important study published at the same time, and actually in the same issue of New England Journal as the BRIDGES study, was the Carrier study by Hu et al. And Fergus Couch's laboratory led this work. And this was very important in showing us some associations in terms of type of breast cancer. So what we see clearly here for ER-positive breast cancer is that key genes include ATM, odds ratio 1.96, CHEK2, odds ratio 2.6, CDH1, odds ratio of 3.37. You can really see which ones are important there. When we look at ER-negative or triple-negative, other things come into play. We can see that ATM is not a significant increase in risk, nor CHEK2, but we see very large odds ratios for BARD1, BRCA1 and 2, PALB2, RAD51C, and RAD51D, which take on more of a role here. And so who's in and who's out right now for breast cancer genes? Well, the established breast cancer susceptibility genes at this point are ATM, BARD1, BRCA1, BRCA2, CDH1, CHEK2, NF1, PALB2, PTEN, RAD51C, RAD51D, STK11, and TP53. We all have questions about some other specific things, one of them being the ATM variant C7271T to G, which may have higher risk than other ATM pathogenic variants and be more in the high penetrance versus moderate penetrance range. There's also lots of discussion about specific CHEK2 missense variants, I157T and S428F, which we think may not confer very much breast cancer risk, and so there is debate about how they should be managed. And then questions about BRIP1 and biallelic NTHL1 as clinically relevant breast cancer genes. Right now, there is consensus that we don't think any of the following are relevant clinically as breast cancer susceptibility genes, namely BLM1, FANC-C, FANC-M, MITF, MRE11, NBN, RAD50, RECQL, RINT1, SMARCA4, or XRCC2. And finally, here are the breast cancer genes with clinical guidelines as to what to do about them from the current National Comprehensive Cancer Network guidelines. So we see here genes listed by descending level of absolute lifetime risk: TP53, BRCA1, BRCA2, PALB2, PTEN, CDH1, and STK11 being the high penetrance genes with risks around or upwards of 50%. And for all of these, we are recommending MRI and mammogram no later than 30, given the early onset. And we are saying that risk-reducing mastectomy should be discussed, given the high risk. When we look at the other genes on this list, CHEK2, NF1, ATM, BARD1, RAD51C and D are moderate penetrance genes. We think generally not above 50% lifetime risk. And here, while we are also still recommending MRI and mammogram, often we are starting at later ages because of the later onset and lower magnitude of risks. And in general, for these, the thinking is that there is insufficient evidence to discuss the option of risk-reducing mastectomy. And then, as I mentioned with BRIP1, the evidence is limited about breast cancer risk. It is stronger for triple-negative breast cancer. At the moment, screening is based on the family history and insufficient evidence for risk-reducing mastectomy. I'll stop here and thank you very much.